Good morning, good afternoon, or good evening, wherever you are. It's really my pleasure and privilege to introduce today our next journal club. My name is Abdelrahman Nimeri. I am the chair of the IFSO Communication Committee. And today we have a very interesting study that we would like to discuss. I have with me today Dr. Luciano Antozzi, and I want to first introduce him and then introduce his study and ask him a few questions. And we really look forward to have everyone join us in the journal club very soon. So Dr. Luciano is an Argentinian surgeon. You can tell from the name that his grandparents are Italian, and he works at the Centro di Cirugía Specialis, which means the Surgical Special Center in the Hospital Italiano Regional de Surgery in Argentina. And he is doing some work currently with Dr. Miguel Carbajo and Miguel Caballero, rather. And he's going to talk to us about a study that was done in Spain at Professor Miguel Carbajo Caballero's center about one anastomosis gastric bypass in adolescents. So this study is a 5-year follow-up of children and adolescents undergoing one anastomosis gastric bypass. And if you can move to the visual abstract, this study involves a small number of patients, but given that it's adolescents and children, this is actually quite interesting. And he's going to talk to us today about what they found at 5 years, their weight loss, how the surgery is done. And I want to first thank Dr. Antozzi for joining us and then ask him a few questions. So I'll let him give us a few introductory remarks.
Thank you, Dr. Nimeri. That pronunciation was perfect. This is a great space from IFSO. I think these journal clubs are excellent because when you write something down, many doubts can come with what people wrote. So it's great to be more specific about many details that sometimes readers have. So this is an interesting paper. It's true, it's only 39 patients. That looks like a small number. When it comes to Dr. Carabajo's experience, he has 3,500 patients operated, and this only means like 1.2%. But anyways, I think there are not many publications about these absorptive techniques besides one-way gastric bypass with this kind of patients. So we had 13 to 19-year-old patients, and then we checked them five years later. It has to be known that there are patients that are at 13 to 14 years operated, so that's a very long term. But we acquainted for the 5-year specifics because we don't have that long-term follow-up for all of them. And we checked with the results with weight loss and compare them with a preoperative situation, and results were quite good. So I think it's going to be nice to present this. Thank you for this opportunity, of course.
Sure. I want to remind everyone that the journal club itself will be on the 23rd of May, and you can look at the time based on your location. If you are based in the US, as I am, it will be 9 a.m. Eastern Standard Time. So I would like Dr. Antozzi, if you can summarize to us the results of the study, if you might.
Sure. Of course, we wanted to see how they managed their weight loss. That was the primary endpoint. But there was a group of patients that was already very sick. They had diabetes, hypertension, and dyslipidemia. On Thursday, we will see the rest of comorbidities, but I think these are the most important ones. And they all resolved very well. When we checked them at 5 years, there was nothing, no medication on any of those comorbidities. And patients are doing a 26 BMI mostly. So the important thing is that patients that are obese when they are adolescents or children, 80% of them are going to become adult obese. So it's not just about what they were when they were studied in the preoperative period, but we know that it was going to get worse with time. So of course, with pediatricians working with us, decisions, this tough decision was called, and results were very good, excellent results. So it has to be known that one anastomosis gastric bypass as performed by Dr. Carvalho is not the same as MGB as described by Routledge. There are some technical details that will be shown on Thursday. As you can see in the visual abstract, in fact, there's a 60% biliopancreatic limb and a 40% common limb. So that's not as Routledge technique that makes a fixed limb length. So there are many details that will be discussed on Thursday.
Sure, that's really quite interesting. So I have a question about the technique, which you just mentioned that it's different than the technique described by Dr. Routledge. So recently, as you know, the French Omega trial showed in a multi-center prospective randomized trial at 2 years that when they looked at the biliopancreatic limb of 200 centimeters in one anastomosis gastric bypass, randomized to 50 centimeters 50 centimeters BP limb and 150 Roux limb in Roux-en-Y gastric bypass. At 2 years, they found higher rates of diarrhea, styrorrhea, and malnutrition, as well as marginal ulceration in the one anastomosis gastric bypass group. And they were concerned that these are significant issues. Now, my first question is, do you think this will be an issue long-term in these adolescents? That's one. And the second question is, how is it that Professor Carvalho and your group performs 60 centimeter BP limb, which if I do the math, someone has a 600 centimeter of bowel, your BP limb is 400 centimeters. If their bowel is 8 meters,
60%.
Their BP limb is close to 500. So how is it that these patients do not get nutritional deficiencies?
Absolutely, that's a great question. About the iOmega trial, that was hard work. But we all know that those kind of trials are very hard work, and we appreciate Maud Roberts' effort for that. But the first thing I want to say is that it's about MGB. It's not a minor thing. They had lost follow-up. I didn't like that part. It's very hard to follow up patients. It was very hard to recruit these patients for the 5-year follow-up. Many of them were lost in the 3 and 4 year. They were doing okay on year 1 and year 2, the honeymoon of bariatric surgery, but then they lose for follow-up, and gathering them for the 5-year follow-up was hard. So I know that loss of follow-up is frequent, but Y-Omega had 26% loss of follow-up at 2 years. Many of the techniques that are compared within the 2 years range regarding results have similar results. I mean, there are papers there comparing gastric bands, sleeves, gastric bypass, and everything looks quite the same in the first period. But I think that the main disadvantage of Roux-en-Y gastric bypass comes in the long term with weight regain. So maybe that will be a problem in the future. We'll have to wait for the result, of course. And if you join the single adverse events in the long term and in the late and the early single adverse event of that paper, they come all together and there's no significant difference. Of course, if you go many other ways, you can see some topics that Roux-en-Y was superior. About diarrhea, they used the Gickley score. Gickley score involves a lot of things besides diarrhea. So I think that can be better measured. About steatorrhea was measured by grams of fat in 100 grams tools, and that was a 4-gram difference in each one. And patients with one anastomosis gastric bypass have to know that if they eat fat, they are gonna have steatorrhea. It's part of the surgery. So I don't know how far that goes when we talk about a complication, but it's obvious that they are gonna have steatorrhea if they eat fat. And regarding GERD and other things, when they joined everything in a chart and found bile in the stomach or gastritis or esophagitis, there was esophagitis on both groups. There was gastritis on both groups. The only significant difference was that there was bile in the stomach in the gastric pouch. I think that's correct. The same is happening with us. We are doing endoscopies on patients operated, and we find usually some gastritis in the distal third of the pouch, and that's usual. I don't know how that will be in the future, if it's going to be a problem or not, but it doesn't behave like Billroth 2 surgery. So I think we are talking too much about this without knowing results. Of course, everybody wants long-term results, and that's what we're trying to do. Try to give long-term results.
Sure. What is the follow-up rate of your patients at 5 years?
Yeah, we had a great decline in the third and fourth year. That wasn't good. But when we wanted to write the paper, we were calling the patients again and trying to get their follow-up. And on the results shown in the paper that will be there on Thursday, all the patients included in this paper had a 5-year follow-up result. So we know everything about them at the 5-year follow-up. The group with comorbidity was not very big, so that kind of loses impact because it was a small group. But this is just about diabetes, hypertension, and dyslipidemia. We couldn't evaluate many other comorbidities like liver steatosis. That was very frequent, like 38% of patients had liver steatosis before surgery, or apnea-hypopnea syndrome. So we just evaluated these 3 parts because they were the easy parts to consider.
So I have many other questions, but I'll leave them for the general club. I want to know, how was the liver cirrhosis diagnosed? I want to know the process by which you and your group decide what procedure to choose for an adolescent. But I want to just conclude by 2 comments. First one is, I want to remind everyone that the 23rd of May, 3 p.m. Europe time, 9 a.m. Eastern Standard Time, will be the 1-hour journal club in a webinar format with Dr. Luciano Antozzi, presenting the 5-year follow-up of children and adolescents undergoing one anastomosis gastric bypass from Professor Miguel Carbajo's group. The second comment is, we tell surgeons that if they do one anastomosis gastric bypass, they should make a long pouch, they should measure all the bowel, they should close Peterson's space, and they should do follow-up surveillance endoscopy. Can you comment about what do you guys recommend in your practice?
Absolutely. In my own experience, besides Miguel's experience, when we first started with OHB, it was very hard to have that mind plasticity to go from a Roux-en-Y pouch to the really long pouch performed in one anastomosis gastric bypass. And everybody's talking about that. It makes a huge difference, mainly because of risk of GERD. So the pouch, it has to be at least 15 to 18 centimeters. So to do that, one has some references, but it has to be long. The technique should be learned from someone with a lot of experience, because sometimes we interpret things like we read, but it's very different when we see someone doing it. The pouch mainly goes down almost to the colon, so it has to be very long. we adopted Carvajo technique that he makes an anti-reflux procedure. It's called anti-reflux, but it's mainly a suture that goes from the biliopancreatic limb to the pouch, and that leaves the anastomosis without tension. I think it makes things very comfortable, and total bowel length is the main difference between MGB and OHB. It has to be counted. It has to be counted. This mainly here in Spain, there's an average of 4 meters of bowel length, as you could see in the paper. But there's going to be a 3% of patients that go below that, and a 6% of patients that go higher than that. So you can have like 9 to 10% of complications just because not measuring the entire length. So it's a simple procedure. I think that if you put the trocars appropriately, you can really count the entire bowel length easily. It's part of the technique. It has to be done.
And how about closure of Peterson space and surveillance endoscopy?
We are not doing closure of the Peterson space. Miguel does put some glue when he uses glue in the anastomosis as prevention for leaks. He hasn't had a leak in a lot of time, but he does it, and part of the glue goes down to the biliopancreatic limb. He used to fixate the biliopancreatic limb to the stomach to avoid any kind of herniation there. But I think that the main difference with RO and Y is that there's no measures, no cutting of the bowel, and I don't know how, but we don't see any pictures in herniation. Of course, there's a space. Of course, there's a space. Every time you get bowel up there, you get a space back there. But I don't know why, but the bowel can go that way. It's interesting. It's interesting, really. EGDs,
how about surveillance endoscopy?
Yeah, surveillance endoscopy at the 5th year it has to be done. I think that what was talked about cancer in future when compared with benign peptide ulcer disease. Cancer there was found in the really long term, I mean more than 25 years. So making this endoscopy is going to be to have some information, but maybe 20 years later, patients should have routine endoscopies less far away from that point. But at the 5th year, it has to be done. We don't do them if they don't have any symptoms, but we like to have a 5-year follow-up endoscopy result.
Sure. Well, again, I want to thank you again for connecting with us today, and I look forward to connecting with you in 3 days on Thursday, 3 p.m. Europe time, 9 a.m. Eastern Standard Time. And I look forward to you showing us how do you guys measure the bowel and how do you place your ports as well. Again, thank you very much, and see you on Thursday.
Okay, see you. Thank you, Dr. Nimeri.
Okay, bye-bye.